Yeah, good evening, sir, and good evening, all my doctors and seniors. Today is a virtual platform, and we are organized a pediatric ECME. And today's topic is covered. Every wheeze is not asthmatic wheeze. We are fortunate enough that Dr. Partha Pratim Borah, he is the renowned pediatrician and neonatologist of the Pratiksha Hospital, Guwahati, and sir is having the vast knowledge of the bronchoscopy, and he is the trained pediatric bronchoscopy from National University Hospital in Singapore. And sir is the first introducer initiated by the pediatric flexible bronchoscopy to entire Northeast region, including 8 states. So this is the virtual platform, and we are organizing sir is having the wide case studies also is there, and all vast presentation is there. So we are fortunate enough to sir is having sir is present here, and all these topics sir will cover. And I am not wasting your time. So the all pediatrician and all my senior doctors are present to ready to say, here to the listen of the sir speech. So I am hand over the session. I welcome you, sir. Please hand over the session to Dr. Borah. Thank you, sir.
Yeah, good evening, Arup, and good evening, everyone there in the virtual world. First of all, I'd like to thank the Lupin Respira Spiritus team for giving me the opportunity to discuss and to share knowledge with all the learned pediatricians who are there in the connecting with us. Today, our topic, has already been discussed by Arup, is every wheeze is not an asthmatic wheeze. Just a minute. Not asthmatic wheeze. So we'll straight away go to the topic. Since as pediatricians, most of our day-to-day practice, we come across this problem of a wheezy child. And before the COVID times, as well as during this, as the winter set in, we are seeing a lot of children, or especially infants and less than under 5 children, who comes to our OPD with cough and wheeze frequently. And it forms a major chunk of our OPD practice actually. And at most of the times also, we are often confused, or often we are in a dilemma that the child that we are approaching, or that the child we are examining with the presenting with cough and wheeze, is it asthma, or is the child having some other problem which we need to deal with? Because if the child has got, if you can come to a diagnosis, or if you can manage treatment, offer treatment to the child earlier, the outcome of the child improves actually. So it is very important that we keep a very strict protocol-based approach to a child who is presenting with wheeze in our OPD. What really is the definition and physiology of wheezing? So as from our MBBS days, from our clinical days, we know that wheezing is basically a continuous musical sound which we hear during the when we auscultate the chest, and it is said the scientific that it lasts for more than around 20 to 50 milliseconds. It is basically produced by the oscillation of the opposing walls on an airway, which is narrowed almost to the point of closure, and it can be high pitch as well as low pitch, and can have both, either can have single notes or can present with multiple notes, and can occur in both during the stage of inspiration as well as during the phase of expiration. So it is very important that whenever we auscultate the chest, we need to look out at the when is the wheezing occurring. So it basically can originate from any side of the airway, from the proximal conducting airways, and it requires sufficient airflow to generate air oscillations, and it produces sound in addition to narrowing or compression of the airway. So we basically see, whenever we see a child with wheezing, we think of bronchospasms. So thus the absence of wheezing in a patient who presents with acute asthma may be an ominous finding, suggesting impending respiratory failure. Maybe there is the air entry is less, the air which has not been able to produce the wheezing sound. So as per the American Thoracic Society documents, the definition of by the American Thoracic Society Committee on Pulmonary Nomenclature defines wheezing as a high-pitched continuous sound with a dominant frequency of around 40 Hz of more. So how do we differentiate? There's a common term which is used in concomitantly, and sometimes we say it is wheezing, or sometimes it's called bronchi. So some experts can distinguish between wheezes and bronchi based upon the type of frequency, the type of pitch, the type of sound, whether it's a single note, it's a multiple note, what is the pitch of sound, or is it a high quality sound or a low quality pitch. It may have a dominant frequency. Sometimes it could be greater than 40 hertz, 400 hertz, and whereas bronchitis could be of lower frequencies. However, the clinical significance of this distinction, if any, is not well defined. It's very difficult to comment whether it's a wheeze or bronchi, whatever. Whenever we see a child with wheezing, we always try to have some differential diagnosis as per the age. If a child present in infancy, whether a child is presenting at childhood or is during the adolescence. So in a child who is less than 1 year, or in a neonate or in an infant with the child present to wheezing, we should always try to rule out airway anomalies. The most common are the malasias. If there's a frequent episodes, if the child is not thriving well, we should think about cystic fibrosis. If there's a history of sudden onset of this wheezing, along with cough, we can think about foreign body ingestion. And there are certain other diseases which always should keep our antennas alert, like primary ciliary dyskinesis, whether this disease, although the disease exists, but we often miss these diseases. There are certain uncommon things like congenital anomalies, like vascular rings compressing over the trachea or the bronchuses, can also present with wheezing in children. Or we can have aspiration syndromes, GER, children with failure to thrive, vomiting episodes, presenting with wheezing, we can think about GER. But in children, but in those who are adolescent or childhood, if a child presented with cough, with wheezing, the first differential diagnosis that usually comes into our mind is the asthma. The less common are the cystic fibrosis. We can also think about PCDs. The airway malasias will not think about. And of course, we should keep in mind. And in adolescents, of course, the most commonest cause would be a case of asthma. So what are the risk factors for a preschool wheeze, which is the most common entity which we come across during our OPD practices? So wheezing in preschool could be there are a lot of host factors which can lead to wheezing in children. Children who are atopic, children with family history of atopy, children with history of eczema, children with associated allergic rhinitis, they can all present with wheezing during the preschool periods. Maternal history of atopy, maternal history of smoking during pregnancy, maternal exposures. In fact, children who are delivered by LSCS, cesarean sections, in comparison to the children with normal delivery, we see that the children are more prone to develop, more prone to atopies, and they can have more prone to wheezing. Children who are born preterm, premature babies, children who had during the prenatal period they were ventilated, they received surfactant therapies. They are also prone to preschool wheezing in the earlier phase of life. But this wheezing can be either transient or they can be either persistent. So as we keep observing the child over a period of time, we'll be able to know whether this persistent wheezing is later on going to develop asthma in children, or it is going to disappear, or the child going to become asymptomatic as a child grows. So it depends upon the immune response of the child, the allergic inflammation, as well as the remodeling of the airways. So there are factors which are associated with wheezing. The most common are the maternal habits and conditions during pregnancies. They can also contribute to wheezing in infants. Children born to asthmatic mothers or family history of atopy, there's always a risk of developing asthma in the later life. Children who are born to mothers who smoke while pregnancy, this is also one factor. Environmental pollution plays a very important role, especially there's a new researches which have come up, and they say the increase in the nitrous amount in the environment makes the child prone to asthmatic or into atopy, and these children can have a lot of remodeling in the airways. Virus infections, which are very common during this period of time, especially the RSV viruses, respiratory syncytial viruses, the rhinoviruses, and other viruses like the parainfluenza virus, the metapneumovirus, they can all increase the, could contribute to the preschool wheezings. So how do you classify basically wheeze? We classify wheeze based on according to the pattern as well as according to the duration. So classification of wheeze could be according to pattern, could be whether episodic wheeze or could be a multi-trigger wheeze. So episodic wheeze, a child can have wheeze associated with a viral infections. They can have a viral cough and cold associated with wheezing. These children, this is which is known as episodic wheeze. And sometimes it could be multi-trigger wheeze. Without an episode of viral infection, the child can present to our OPDs with wheezing. So there are a lot of studies which have come up with this, whether we can, based on either the child is early episodic wheeze or a multi-trigger wheeze, whether the children will go on to develop asthma or not. So it often, there's a difference between there's a quantitative difference, but it's not qualitative basically. And the frequency of severity of the wheezing episodes are stronger predictors of long-term outcome. This is very important. If we see a child with wheezing or a child who comes to our OPD frequently, it is important how frequent the episodes are or how severe the wheezing episodes are. So the majority of children with troublesome episodic viral wheeze, they get, every time they get a viral infection, they get a wheezing. They often refer to a secondary care clinic, remain symptomatic at the age of 5 to 10 years. And a number of these children have developed symptoms between episodes, more likely to have can have multi-trigger wheeze also. So there's a study by Avon and Lester who shows that a large proportion of children with multi-trigger wheeze became symptomatic, and those that continue to wheeze shows a tendency to remain in the same phenotype. So based on duration, it could be the infrequent child can have present with wheezing once in their life. Sometimes they can have transient early wheeze, which presents in the first year of life, and then it continues up to the second year, and by the third year of life, usually the symptoms starts disappearing. And most of these patients are usually non-atopic. Sometimes they can have intermediate wheezing. This condition presents wheezing with onset between around 18 to 42 months of life, and they persist up to the later childhood. And these are children who are strongly associated with atopy. They can have allergic sensitizations. They can be hyperresponsiveness. And whenever we do a pulmonary function test, they can have a lower PFT scores. These are children who can continue to have wheezing in the later part of childhood to the adolescence. So according to duration, there could be late onset wheezing that presents infrequent wheezing between 6 to 42 months of life and becomes more frequent between 42 months of life and then persists to an age of 6 years. There could be persistent wheeze, which is almost similar to asthma. And however, the GINA guidelines state that the wheezing phenotypes as described previously are not stable phenotypes. A child can migrate from one phenotype to the other. So the keen observation of the child, examination of the child, and we need to look out for smaller things through which we can diagnose the children early. So according to the cause and mechanism of childhood of wheeze, the cause could be either viral infection, there could be atopy, allergic sensitization, exercise, environmental pollutions like smoke, indoor pollutions. This can all lead to a series of bronchospasms and wheezing phenomena. The viral infection can lead to bronchiolitis, there could be viral-induced wheeze, there could be inflammation in the airways, and as well as the atopy and exercise-induced, indoor or outdoor pollutant-induced can lead to asthma or bronchospasms in the later part of life. So there are different clinical conditions which can present with wheezings. Most commonest are the associated with viral infections like croup, whooping cough, laryngeal or acute tracheobronchitis, airway anomalies, which are often we see in children with children presenting in wheezing in the early infancies, like with laryngotracheobronchomalacias. Sometimes there could be tracheal tumors, and sometimes there could be foreign body aspiration, which can present in wheezing. And sometimes there could be large airway compression either by stenosis or by vascular compressions. And there could be other diseases like hypersensitive pneumonitis, interstitial fibrosis, there could be pulmonary edema. And sometimes if you see this hypersensitive pneumonitis, especially in the northern belt as well as in the eastern region, it's a very common phenomenon. Children who are force-fed with lentils, they often present with wheezing during the early phase of life. And this is due to the lentil hypersensitivity. So what are the common causes of wheezing? There could be association with atopy and wheeze association. The numerous studies have supported an association between atopy and wheezing. Atopy presentation include there could be asthma in the family, there could be signs of allergic rhinitis, there could be itchy eyes, redness in the eyes, excessive tearing from the eyes, signs of allergic rhinitis like sneezing, nasal itching, snoring, nasal blockage, difficulty in breathing, especially at night, and there could be associated eczema. So additionally, in rare cases, children may wheeze because of an allergy to milk and other types of foods also. So how do we evaluate a child who presents in our OPD with wheezing? So we'll just go through a few cases as we have discussed about the different clinical conditions which can present with wheezing. We'll just go through 4 or 5 cases to see how the children are presented in our OPD, and they have come up, although they were diagnosed as asthma or they were prescribed with inhaler therapies, but we could often when we examine them, we came up with some other diagnosis. So this is a 4-year-old infant who presented to our institution with history of repeated hospitalization for wheezing and respiratory distress. He was a term baby. His neonatal period was uneventful. The infant developed the first episode of wheeze when he was around just 3 months of age. This is a very pertinent point. Any child who presents in the early phase of life was initially diagnosed with bronchiolitis. He developed later on, went on to develop recurrent wheezing, was treated with bronchodilators, antibiotics. And when the child was admitted in a hospital, he was dyspneic, was bilateral wheeze was present. And when we did a chest X-ray, there was hyperaeration in the lung. Since there was a history of recurrent history and with the presentation in the early infancy, we did a bronchoscopy in the child to examine the airways. This is often we miss the children. If you could see, this is where we are inside the trachea, and we could see that there is tracheal compression. Usually, trachea is a C-shaped structure, and if the tracheal compression is more than 1/3 of the normal tracheal diameter, we diagnose in the child with tracheomalacia. With tracheomalacia, what happened? The ciliary functioning of the lungs and the lower proximal airways are damaged, because of which there is improper clearing of the airway secretions, and these children often present with persistent cough, or they can present with persistent wheezing during the early phase of life. The most important point to remember is this, that these children usually doesn't improve to bronchodilator therapies. And at times, when they take a history, often the parents will say that the child has in fact deteriorated after giving nebulization with bronchodilators, because as these are mellitic airways, the airways are quite soft, and as we give them beta agonist or we give them with nebulize them with bronchodilators, the airway becomes soft and it collapses further. So the child in fact at many a times deteriorates. So the child in fact they improve with physiotherapy and with postural drainage. So as we come to diagnosis, we put the child on physiotherapy and on postural drainage, and the child improved gradually. The child became asymptomatic, and there was weight gain also. This is the second case. This is an 18-month-old male child who presented with recurrent cough with wheezing for the last 3 months. There's a term baby. His neonatal period uneventful. There was history of cough, respiratory distress requiring hospitalization, and he's been receiving nebulization since 6 months of age. The family history of atopy was also there. His mother was also asthmatic. So there's a strong predilection for atopy. At the time of admission, the child was tachypnic. His chest has bilateral wheeze. There was fine crepitations, and the X-ray shows hyperaerated lung fills. We did a bronchoscopy in the child for 18-month-old child with recurrent wheezing and coughing. And to our surprise, as we went into the airways, we will see that there is a foreign body. Now, since this foreign body is not lodged, you can see the foreign body in the trachea now, and after some time the foreign body will disappear. And this foreign body actually is a migratory foreign body. It just keep moving with the lungs. Now it has disappeared. It has gone into the right bronchus, and after some time it will again come up and will enter into the left bronchus. It has come up to the right bronchus. So that even if you do a chest X-ray in these children, we are often going to miss these children because we are not going to see any hyperaerated or a lung fills or a hyperlucent lung fill. And when you do the bronchoscopy, we could see that this is a piece of peanut actually, which is moving from one bronchus to the other, and which is giving now it has gone to the left bronchus. So we could just remove the foreign body, and the child is absolutely fine the next day, and he can go back home. So foreign body inhalation is a very common worldwide, and children between 1 to 5 years of age are more commonly affected. An indicative radiograph doesn't exclude the presence of foreign body, and foreign body migration has been previously reported, and this is mostly because of the high flows generated by the coughing, and sometimes we might find the inorganic and the smooth foreign bodies, which are often likely to migrate. So our third case, a 6-month-old boy, was referred for evaluation for persistent cough and wheezing actually, and his respiratory symptoms gradually increased for the last 3 months. And the wheezing episodes were poorly responding to nebulization therapy. The child was tachypneic at the time of admission. There was decreased air entry and there was bilateral lung fills, and there was polyphonic wheezing present on bilaterally. We did a HRCT thorax also. We could see a compression in the proximal trachea, and we did a bronchoscopy. So for our, interestingly, we could see a tracheal mass as obscuring the tracheal lumen and resulting in cough, persistent cough, as well as the persistent wheezing. Most of these tracheal masses are usually soft tissue, soft tumors. For in our case, it was a hematoma, and we could bypass the scope through the by the side of this tumor, and we can look into the bronchus also, and both the bronchuses were normal, and there was no other abnormality. As the child, the tumor was removed, and the child was absolutely normal. So now this is a 10-year-old boy, basically, who is presenting with productive cough. It was for a prolonged period, and there was history of shortness of breath and wheezing. It has been there since childhood, and this is a point where you need to look at the anthropometry. We need to do a good clinical examination. And this child had there was history of weight loss, and the child was not growing well. It was less than the 10th percentile. And when we examined, there was digital clubbing. So whenever we have a child who has been diagnosed, even if diagnosed with asthma, if you could see digital clubbing, we should always think about the other diagnoses. There was no history of contact. There was chest X-ray showed hilar lymphadenopathy. And since there was hilar lymphadenopathy and the child was not growing well, he was diagnosed as somebody diagnosed him as TB also, and he was screened for tuberculosis. He was put on combination therapy for his symptoms. He was given 2 weeks course of amoxicillin also. And when we did a CT, there was a spread of bronchiectasis. And even in chest X-ray, if you see signs of bronchiectasis, we should think about cystic fibrosis. And we did a bronchoalveolar lavage in the children, and they grow pseudomonas. And sometimes there could be Staphylococcus aureus or Haemophilus influenzae. And these are strong indicators that the child has cystic fibrosis. And when you did a sweat chloride test, of course, the chloride levels are very high. So whenever we find a child with prolonged cough, failure to thrive, digital clubbing, we should keep our mind open for cystic fibrosis. Especially we need to take a very good history during the neonatal period of any history of delayed process of meconium, infancy in recurrent pneumonia, toddlers, any rectal polyps, failure to thrive, any recurrent pneumonia, and staturia is very important history. And in adults, of course, they can have chronic lung disease and sterility. So, of course, the diagnosis is always a sweat chloride test. We can do gene mutation test, and we can do a transmembrane potential difference of in the nose. And now we have a 12-year-old boy who presented progressive severity of cough and wheezing episodes since early infancy, and there's decreased exercise tolerance. He was initially diagnosed with asthma, atopy, and there was history of TTNB. He has history of otitis media for he required laryngotomy. And of course, when he did a chest X-ray, it shows situs inversus. So whenever there is situs inversus, again, with a prolonged episodes of cough, pneumonia, recurrent pneumonia, episodes of recurrent respiratory tract infections, we should think about PCDs, or the primary ciliary dyskinesis. They can present a nasal discharges, sinusitis, they can have prolonged cough, and of course we need to do a fractional nitric oxide level where we live in low FNO. We can do a nasal nitric oxide test. Of course, if you do a high-speed video microscopy, we'll see the abnormal movement of the cilias, and we can do a mutation analysis. So what are the differential diagnoses? So according to age, we have seen that the child can present it during the infancy, during the childhood, as well as during the adolescence. So whenever we take a history, if there's a history of vomiting or poor weight gain, especially in infant, we should think about GER or any aspiration syndrome. If there's a sudden episodes of coughing, choking, and there is sudden onset of wheezing, we could think about inhaled foreign bodies. Children with persistent symptoms, failure to thrive, we can think about immune deficiencies. I've already discussed about cystic fibrosis, children with poor weight gain because of pancreatic insufficiencies, with digital clubbing, chronic nasal symptoms, rhinorrhea, sinusitis, nasal polyps, we should think about PCDs. And of course, if the child is an infant and you could hear monophonic sounds, especially in the chest, we could think about the airway malasias, most commonly are the tracheomalacias and the bronchomalacias. And of course, if there's a history of prematurity, oxygen dependency for a long time, extremely premature deliveries, history of mechanical ventilation during the in the neonatal period, we think about BPDs, or children presenting with chronic lung diseases. Sometimes cardiac anomalies can also present with wheezing in children, and sometimes what we call as PIBO, or the post-infectious obliteration of bronchiolitis obliterans. These children can sometimes also present with wheezing. So what are the ERS task force recommendations when I approach the preschool wheezing assessment? The pattern and triggers of wheezing, personal and family history of allergies, household smoking should always be assessed during the history. And wheezing reported by parents should be verified always by a very healthcare professional. Allergic testing should be performed in children requiring long-term management. We can go for a skin prick test in the children. And other investigations should be avoided unless the wheezing is unusually severe. Therapy decisions are accompanied by unusual clinical features. What are the clinical clues indicating that there could be other diagnoses, like paroxysmal history of wheezing associated paroxysmal cough? We can think about pertussis, malasias, persistent wet cough in children with cystic fibrosis, aspirations, ciliary dyskinesias. Protected bacterial pancreatitis is, of course, a new entity where children can present with chronic cough, wet cough basically, and not responding to any usual treatment. These children actually do very well with just a course of amoxicillin for a period of 2 weeks. Sometimes with children presenting with purulent nasal discharges, we can think of sinus infections. Children presenting with coughing while feeding. Children with vomiting history, failure to thrive, we can think about gastroesophageal refluxes. Abnormal voice or cry, we can think about anatomical anomalies in the airways. If it is episodic or seasonal, we can think about asthma, finger clubbing as abscess, cystic fibrosis, ciliary dyskinesis, or other immune disorders. If there is failure to thrive, immune disorders, and if it is prematurity or low birth weight, you can think about bronchopulmonary dysplasias or chronic lung disease. Infant wheezing is sometimes mixed with other causes of noisy breathing, including all causes of nasal obstruction in the first 2 years of life. So sometimes even the children with adenoid hypertrophy, the nasal block, can sometimes misinterpreted by parents as wheezing. They'll say the child has got noisy breathing. So whenever the parents complain of noisy breathing, we need to auscultate and look for the signs of bronchospasms. So how do you differentiate between viral wheeze and an asthmatic wheeze, especially in a young child? So viral wheezes are usually associated with other respiratory infections, like the child can have cough along with cold, there could be history of fever, and there could be it could be a single episode, and sometimes they can have multiple episodes, especially in children for less than 2 years of age. But asthmatic wheeze can occur, as we have said, in multi-trigger wheeze. There may not be any history of any predisposing viral infections. Some will have persistent or interval symptoms between episodes of viral wheeze, and they can have cough or wheeze at night or even with exercise. Especially cough occurring in the midnight, usually in the early part of the morning. These are usually associated with wheezing. We should think about asthmatic cough or wheezing. So diagnosis of asthma in under 5 children is mostly clinical. We can take the help of PFTs. PFTs are usually helpful in children who are more than 5 years. We can take the help of impulse oscillometry in the children between 3 to 5 years of age. This is a new parameter which is widely being used. And we can, of course, use asthma predictive index to predict, but it has got a more negative predictive value rather than a positive value. So we can take the help, but we should not be very dogmatic about the predictive index. So if wheezing is frequent more than 4 times in a year, the following criteria can be assessed. So what basically is an asthma predictive index? So asthma predictive index is based on factors that are found in the first 3 years of life to predict or continued wheezing in the school age. So it says that more than 3 episodes of wheezing per year in the first 3 years of life, and there should be present of 1 major or 2 minor criteria. Major criteria could be any family history of asthma, parents having asthma which is documented by a physician, or a child having history of atopy or eczema during the early childhood, which is of course documented. Minor criteria could be allergic rhinitis in the child. There could be wheezing apart from cold, which is reported by the parents, and if there is peripheral eosinophilia greater than or equal to 4%. So what are the investigations that we usually do? So most of the time you'll have a normal chest X-ray. Usually investigations are not required very frequently. A good clinical history and a good clinical examination usually clinches the diagnosis. Of course, if you're thinking about immune deficiencies or other unusual presentation, we need sometimes only we need to go for few invasive investigations. So we can take a bronchoalveolar lavage or a cough swab. If you're thinking about protected bacterial bronchitis, or if you're thinking about cystic fibrosis, sometimes an nasopharyngeal aspirate can be taken to look for any viral infections. Skin prick test is a very beautiful test to identify the specific allergens, any allergic sensitization in the child, which can be dealt with by the immune therapies which are available nowadays. So children should always be referred for further investigations if there are red flag features in this history, and if examination is suggestive of other pathologies or the diagnosis is unclear or in doubt. So what are the red flags basically, which would give us a indication that the child needs to be referred or will need further investigations. So diagnosis, if the diagnosis is unclear or in doubt, the symptoms present from birth or during the parental lung problems, if there is associated excessive vomiting, or there could be persistent weight or productive cough, there is failure to thrive, there is family history of diseases, nasal polyps, there is inspiratory stridor. All these things we can always think about referring the child, or the child might require some other investigations. So in general management, the treatment predominantly revolves around the suspected etiology for wheezing, and we should always ensure that the airway, breathing, and circulations are always maintained. And those with signs of impending respiratory failure may require either non-invasive positive pressure ventilation or invasive mechanical ventilations. In case of anaphylaxis, epinephrine should be required, and sometimes it might require nebulized short-acting beta agonists such as albuterol or salbutamol can be given. So whenever we have a child with recurrent respiratory symptoms, this could be either there could be presence of wheeze, there could be absence of wheeze, or there would be associated recurrent viral infections. For episodic viral wheeze, usually we observe the children. For a multi-trigger wheeze, if there is associated atopy or non-atopy, usually a trial of bronchodilators usually usually the symptoms usually subsides, and sometimes the symptoms are severe wheezing with other respiratory problems. Of course, a dose of oral steroids can be given. Sometimes if you're in doubt, and that we need to check whether the child is having recurrent episodes of wheezing. So in those cases, we can give a trial of inhaled corticosteroids, which is for a period of around 2 to 3 months. This is, in fact, the child responds to this inhaled dose by around 2 weeks to 6 weeks of therapy. We are, of course, sure that the child is having wheezing is mostly because of asthma. But if the child doesn't respond to this inhaled corticosteroids, this trial therapy, then we should think about other symptoms. Of course, Montelukast is a controversy nowadays, although it was widely used earlier. It comes with a level nowadays that prolonged use of Montelukast can cause neuropsychiatric disorders in children. So we are skeptical about this drug nowadays. Azithromycin is a new drug which has been studied, especially when we are talking about different phenotypes in asthmatic children who are neutrophilic predominant phenotypes. These children can have benefits from use of azithromycin, and they are often prescribed azithromycin for a prolonged period to bring down the inflammation, resulting in bronchospasms. And of course, we need to look out the indoor or the outdoor inhalant pollutants. If there's history of smoking in the parents, we need to avoid that. And the very most important thing is the educating the parents regarding the symptoms. And of course, if the child is on any inhaler therapy, we should always look at the technique or whether the compliance, whether the child is taking the therapies properly or not. So in my concluding remarks, wheezing may be either benign or self-limiting process and presenting symptoms of significant respiratory diseases. The role of treating clinician is to try to reach the most likely diagnosis as quickly as I've said earlier, so that if we manage a child early, we can provide a better outcome in the children. The asthma is very common, but other causes are also common and worth considering in the event of poor efficacy of asthma treatment. The presence of wheezing does not always mean that the patient has asthma, and a proper history and physical examination will always help us to come to the diagnosis. So prevention is a major goal to diminish the morbidity of the virally mediated wheezing and asthma exacerbations. And given the impact of viral infection on wheezing and asthma, several host factors could be considered in efforts to treat asthma exacerbations. and more effectively, and to reduce the risk of asthma development. Thank you.
Thank you, sir, for sharing your thoughts on wheezing. So we have few of the questions here. So I'll share one question with you, and you can address them.
Yes, please go ahead.
So there's first question from Dr. Amit, who is from Ahmedabad. He has a question. How do you go about a management of a viral wheeze and a asthmatic wheeze? Can we use a nebulization therapy since both the wheezers respond very well to it?
If the child is presenting with a wheeze, we need to look at the other clinical parameters. If the child is in respiratory distress, or what kind of respiratory problem the child is. If the child is tachypneic, if the child is cyanosed, of course the child need a hospitalization, might require nebulization therapy. If the saturations are less than 95% and there is oxygen requirement. But if a child has got an intermittent wheeze and child is comfortable along with the wheeze, and if the child has been able to maintain saturation and the child is not very tachypneic, I think these children usually respond very well to inhaler therapies. We can use bronchodilator inhaler therapies in the children. Rather than the most important take-home message for all practicing pediatricians is that we should not advocate routinely nebulization therapy. And most of the times what we see is that the parents are advised to buy nebulization machines, and these nebulization machines are rampantly used by the parents. Even for a simple viral cough and cold, they are often used. So we are going to miss children with asthma in those cases. And the frequent use of this nebulization, especially the bronchodilators, can lead to side effects. They can have long-term cardiac side effects, which have been well documented by the GINA guidelines, which came out recently. And so I think we'll always advocate for a inhaler therapy, especially during this COVID time. If the child comes with wheezing, if it's a viral cough, even if it's a viral infection or an asthmatic wheeze, we should advocate use of bronchodilator inhaler therapies.
Thank you, sir. So there is a query from Dr. Sandeep, who is from Guwahati. He asked, like, for how long do you recommend inhaled corticosteroids in management of asthma?
The protocols have just recently changed actually. If you're in doubt, and then if you're just using it as a trial therapy, then short course of ICS can be low dose ICS can be given for a period of 3 months. Earlier we used to give it for 6 months, and then we used to taper it. Now the recommendation is that the child is, even if the child is asymptomatic, after taking for 3 months of period, and the child is asymptomatic, you can stop it. And then if the child develops symptoms again, you can restart it. So there's no definite time guideline nowadays for prolonged use of low dose or the inhaled corticosteroids for a longer period of time.
Thank you, sir. So we have one more query wherein a doctor asked, in which age group of patients do you recommend performing a spirometry?
Usually in a good center, in our center also we are performing spirometry regularly, but even in children between 4 to 6 years of age, even it's sometimes very difficult. But sometimes in 4 or 5 years old also we can perform, but it's always better we can do well in children who are more than 6 years or more than 6 years. They do well, and they usually comply to the steps through which we need to perform this spirometry. So usually in a child who is more than 6 years of age, and they do, it's very easy to do a spirometry.
Thank you, sir. So there's one more query from Dr. Suhas, who is from Kolkata. He asks that, do you prefer omalizumab in management of severe asthma, and what should be the therapy period?
See, in acute severe asthma, there are new drugs which has come up. We have omalizumab. I don't very less frequently. Maybe we will need a child who will require omalizumab, I think. And before coming to a diagnosis of severe asthma, we need to look at the two things that we have already discussed: whether the child is compliant, whether the technique is correct. In those cases only, we can go ahead with the omalizumab therapy.
One doctor shares the case that recently had a patient where it seems that he had an allergy as well as there was also an acidity. The child had a problem. So what should, and also had to mimic the symptoms of asthma as well, wheezing. So what should be the role of management?
Sorry, I couldn't get that question.
Yeah. So I repeat, the question is, recently a doctor had got a case wherein a child was having was complaining of a severe acidity and was also having symptoms of allergic rhinitis, and which also lead to mimicking of also doctor was want to know whether it should be considered as an asthma or how should be the treatment of it.
See, allergic rhinitis, children with allergic rhinitis can also present with cough, especially nocturnal cough. And especially if the child has got a postnasal drip, and sometimes if the child has got an associated adenoid hypertrophy, these children can present with cough and wheezing. Since we know that it's a united airway disease, children with allergic rhinitis can also have associated symptoms of asthma also. There could be hyperactivity in the bronchial hyperactivity. So if the symptoms of allergic rhinitis, like if the child has got frequency of sneezing, the child has got itching nose, the child has got running nose, frequent running nose, there's history of mouth bleeding, there's history of snoring, I think we can, the child has got associated wheezing also. So both these diseases have to be treated concomitantly. You have to treat him for allergic rhinitis as well as for asthma, both.
So there is one interesting query from one of the doctor. It seems that how do you, the doctor is Dr. Dev, who is from Delhi. He has a question, how do you manage a cystic fibrosis in your patient, since you need to be in touch with them for their entire therapy. So how do you go about management of cystic fibrosis?
For managing cystic fibrosis, it's a very especially in the northeastern part of India, we don't have much of a cases. We have just recently we have come around 3 to 4 cases of cystic fibrosis. It requires a big team of people. You need a good, the most important part is role played by the physiotherapists, the chest physiotherapists, your dietitians, and then of course you have to look into the chest problem also. This requires pancreatic, because of the pancreatic insufficiency, they require supplements, they require it's a big team effort to manage the children, and especially for pediatricians. Of course, what is difficult is that you manage them up to adolescence, and then you have to hand over him to an adult pulmonologist or adult specialist.
Thank you. So this is query from Dr. Sagar, who is from Mumbai. He has a query where when you are performing a bronchoscopy in the current COVID times, do you prefer to do it in a negative pressure room, or how do you do it in the recent current times?
We have been doing bronchoscopy during the COVID time also. Of course, we do have RT-PCR test before taking the patient. But of course, if it's an emergency, we have to do it. We take all the necessary precautions that we have, all wearing PPEs. It's very difficult to do a bronchoscopy wearing PPEs. Ours, of course, is a bronchoscopy suit, so it's a negative pressure room already, so we don't have much problem with it. We use we have a special valve mask through which actually we are doing the bronchoscopy. We just don't put the scope directly into through the nostrils. We put a mask in front of the baby's mouth and nose, and through the mask we are putting the scope. So that's so as to prevent the aerosol spread.
Thank you, sir. So there is one query from a Dr. Manjusha. She has a query from like in many webinars, there is a newer tools and diagnosis of the asthma that is talking about the usage of the fractionally exhaled nitric oxide. So what is since your view on it management of asthma? See,
the FeNO has come recently, and the low FeNO is a very good indicator for children with eosinophilic phenotype. In those children, you could just put a nasal cannula, and on your laptop or on the screen, you can find out the level of the fractional nitric oxide. This is a new entity. I don't think it's available everywhere. We don't have it in Guwahati city. It's available. I think nearest would be available in Calcutta, and there are a few good centers in India only who has this FeNO. I think, but in the near futures, maybe once these equipments are becomes accessible, becomes cheaper, this will be available everywhere. But of course, it's a very good entity. But of course, we cannot, for asthma diagnosis, we cannot just rely on investigations. Asthma is basically a clinical diagnosis. And the best way is to take a very good history, very good clinical examination, and then the trial of therapy. And this is how you can come to a diagnosis of asthma.
So there is one query from Dr. Deb, who asks that how would you go now for management of the flare-ups in asthma with this seasonal change?
It depends upon the age group actually. If you're dealing with a child who is more than 6 years of age, who is already on a long-acting beta-2 agonist along with a steroid therapy, these children can what the new GINA guideline says, you can directly give them. This can be used as a reliever therapy also. But for a child who is less than 6 years of age, you can give as for the flare-ups, you can use the bronchodilator therapy, the short-acting beta-2 agonist as a reliever therapy. And if that, along with the beta-2 agonist, you can start with the low-dose inhaled corticosteroids also to prevent the flare-ups.
So there is one query from Dr. Krutat, who asks that what is your preference in management of an uncontrolled asthma? Do you prefer starts with ICS or starts with ICS plus NAPA?
It all depends upon the age group, as I've already said. If it's a child who is less than 6 years of age, of course, I'll go for a ICS only. But depending upon the symptoms, severity, and frequency of attacks. If the child's symptoms are severe, the child presenting with life-threatening episode in the initial attack, in the initial presentations, if the child got frequent episodes of wheezing, the child, if the episodes are severe, and then of course we need to, if the child is more than 6 years of age, we can use either, we can have the combinations, the long-acting, the SABAs and the along with LABAs, along with the steroid therapies. But the child with less than 6 years, it of course will go for a with the short-acting beta agonist as a reliever and with a ICS as a controller therapy.
Thank you, sir. So this were the queries which we have received from the delegates who are viewing us today. So I would like to thank you from behalf of Lupin, respiratory teams, for giving your valuable time at this hour of the time in the day and sharing your thoughts on every Wheeze is not asthmatic Wheeze, wherein you have very well taken us through all the pointers and also shown about few of your cases as well as the bronchoscopy, which was quite interesting to the delegates, because some of the delegates has also appreciated the talks on today's session. So thank you, sir, for having your talk with us. Thank you, sir.
Thank you so much, Lakshmi. Thank you, Arun.
Thank you so much. Thank you so much.
It was indeed a very nice experience for me also. Thank you. Thanks a lot.
Thank you, sir.
Thank you, sir. Yeah.